Good afternoon, everyone, and welcome to this ESICM webinar entitled Environmental Sustainability, Pathways to Sustainable Intensive Care. My name is Jan de Waele, and I'm honored to moderate today's session. As intensive care professionals, we dedicate our careers to saving and improving others' lives, but we must also acknowledge the environmental footprint of our work. The healthcare sector itself contributes significantly to the global burden of carbon emissions, and intensive care is no exception. So clearly our responsibility extends beyond patient care to include safeguarding the health of our planet. At ESICM, sustainability is a key priority, and earlier this year, we launched the ESICM Green Paper on environmental sustainability. This document is a call to action, providing a roadmap for making our intensive care units greener without compromising the quality of care. It highlights practical strategies ranging from reducing waste and energy consumption to fostering sustainable procurement and education. This webinar, in fact, is part of our ongoing efforts to translate the vision of the Green Paper into action. And today, we've brought together experts who will share their insights and actionable steps for making sustainable changes in your own ICUs. I encourage you to think about how these ideas could inspire your initiatives in your own context. So before we go to the presentations, I would like to add that this webinar is supported by an educational grant from GE Healthcare. If you have any questions that come up during the presentations, we'll deal with those at the end, but you can share them through the chat function in the video you're watching. So thank you very much for joining, and let's dive in. So we have three exciting speakers, and today the first speaker is Marlies Osterman from London, UK, who will be talking on interactions between intensive care and the environment to help us better understand how our own activities impact the environment. Marlies, the floor is yours.
Thank you, Jan, and thank you to the ESICM and the sponsor for organizing this very important webinar. It's a great honor to talk about the interaction between intensive care and the environment. And I put it to you, and I will hopefully convince you, this is a bi-directional relationship. I have no conflicts related to this talk. Now, when you see pictures like this, it is obvious that some of these people will end up in hospital, and some of them will be admitted to the intensive care unit. So the impact of climate change affects patients and increases their risk of being hurt, being injured, and developing the diseases. And these climate-related hazards go from heat waves to pollution to earthquakes, and also flooding. And you can think of many natural disasters that will have an immediate effect on people's health, either by directly damaging people or by destroying the environment and the infrastructure. And as usual, people who are more vulnerable are at higher risk. Now, our body has to get used to the fact that we have to adapt to some of these natural disasters. Now, we have mechanisms in place already to, for instance, cope with heat. But during these extreme temperatures, these physiological mechanisms are not adequate, and patients' health may deteriorate. So in extreme heat, patients often experience cardiovascular problems. They may feel dizzy. They may fall. It's also clear they may become volume deplete because our sweat mechanism may reduce intravascular volume. They may not be able to drink. And ultimately, heat and extreme heats can directly contribute to organ dysfunction and actually multi-organ failure. In fact, there is literature showing an increased risk of diseases of cardiovascular and respiratory morbidity in extreme weather in extreme temperatures. Here we have a paper where they looked at the literature until 2018 to describe the impact of heat waves on cardiovascular and respiratory mobility. And there's lots of data in the literature from 20 countries and even more. And this systematic review clearly showed an association between heat waves and cardiovascular mortality, also respiratory mortality. And as I've already mentioned, the risk of mortality or risk of dying during these heat waves was higher in people who had significant underlying chronic comorbidities. Now, this is a link between natural disasters, heat waves, and mortality, but a lot of these patients would have been in hospital and some would have been in the intensive care unit before they died. Here's another paper where they again looked at non-optimal temperature exposure, so too cold or being too hot, and again showing a clear link between natural disasters and death. So they looked at almost 65 coded deaths from 9 countries, and again showed an association between extreme weathers, extreme temperatures, and an increased risk of dying from cardiovascular, respiratory problems, but also other medical problems. And importantly, they showed that people's behavior changes, then also contributing to death. So people may feel more vulnerable, so there's an increased risk of violence, there may be an increased risk of aggression, and again, accidents occurred. And some of these people who were recorded in this death register were in the intensive care unit before. So it's obvious from these reports that climate changes affect the people we see in the intensive care unit and increases the risk of dying. I've already said it also changes our behavior because we may be a bit more irritable, we may feel more depressed, there may be more violence, but it also, heat waves and temperature changes change the behavior of organisms, as we now know. And here is an extract from the WHO website from September this year, where they alerted healthcare clinicians about the fact that vector-borne diseases like malaria and dengue fever, which are normally in particular countries in the world, are now spreading, and they are spreading across the world and have been detected in countries that are usually not used to looking after patients with dengue or malaria. So the profile of people in the intensive care unit is already changing and is likely to change more. This was also highlighted in this landmark paper in Nature Climate Change, where they essentially looked at the impact of climate change, which you have on the left, all the things which happen as a result of climate change, so storms and floods and heat waves. Then we have the various organisms in the middle and their characteristics. And it's very clear that these interactions between natural disasters and the characteristics of these organisms are changing. And we see a different pattern of infectious diseases now in hospital and also in the intensive care unit, affecting almost all organisms. Now, I've focused on patients, but we also have to accept and acknowledge that natural disasters, changes in climate, affect the way we feel, the way we interact. And it's very clear that, for instance, heat waves affect staff in the intensive care unit. And this is important because the data in the literature clearly show that especially heat waves reduce healthcare staff's cognitive function, are associated with an increased risk of making mistakes, and lead to absences at work. So the environmental changes affect patients, affect the organisms, and affect us as healthcare professionals. And this slide from, again, the WHO website highlights some of the dangers that we're going to face in the next few years. It's likely, very likely, that heat-related deaths are going to go up rapidly. that labor loss will occur, that a large number of people across the world will face food insecurity, and that the profile of infectious diseases will change, and vector-borne diseases in particular will be able to spread. So environmental changes, climate change affects healthcare. But I've already said it's a bidirectional relationship because we as healthcare professionals contribute to this. It's clear that healthcare is a major contributor to CO2 emission. And we often think of buildings, and we may think of windows not being tight and maybe the electricity. But actually, when you look at this in more detail, and it's the healthcare itself rather than the building and the infrastructure, which contributes to equivalent CO2 emission. And if you really think of the intensive care unit, then you won't be surprised because we use a lot of resources. We use a lot of devices, we do a lot of tests, and we create a huge amount of waste. And we do a lot of things, and some of them are routine, but it should be remembered that even routine things like doing a blood test, simple phlebotomy, essentially means that we are consuming resources, very essential resources, and we're creating waste. And colleagues in Australia looked at the impact of just 5 common hospital pathology tests. So blood tests which we do routinely every day, several times a day. And they looked at the average CO2 equivalent emission. Now, for a start, there are differences, and that all comes down to the fact that we may use different vacutainers and different specimen bags for these various blood tests. At first glance, these differences may not matter and may seem trivial. But actually, if you then look at 1,000 tests and you compare this with driving a car, then it is eye-opening, scary how much CO2 is produced just from doing these very routine blood tests 1,000 times. Nicole Hoenfeld, who is one of the speakers here at the webinar, again, is leading in this and looked at many things in the routine clinical practice. And as you will know from this landmark paper, she clearly demonstrated that we use large amounts of routine consumables when caring for a patient, and they're listed here. But again, they create a large amount of waste, but also obviously give us opportunities to potentially reduce the use and reduce waste and money, and potentially help the patient and increase their benefit, lead to patient benefit. Just to highlight this again, an extract from this paper, again, a recent paper, where the team calculated the costs of caring for an ICU patient with septic shock. And they calculated, estimated that the cost or the impact of looking after a patient with septic shock in a US intensive care unit was similar to a one-way economy class flight for one passenger from New York to Mexico City. So the things we do routinely already contribute to CO2 emission. But there are obviously a few other things which also should remind us and potentially get us to think differently. We routinely use single-use devices in many intensive care units rather than reusable devices. We sadly also contribute to waste by not paying enough attention to expiry dates. And we have stores like this where material can easily get wasted because they didn't get used before the expiry date. And then lastly, it's also clear that some of the things we do are of very low value, are not necessary, and although they may cost money, it's very clear they also contribute to the impact on CO2 emission. And when looking at the role of healthcare, we have to face the fact that there are things we do unnecessarily and that we do overtreat some patients. And whatever we do obviously uses resources, but also contributes to waste. And I just want to finish with an example related to renal replacement therapy, just to make my point. Now, clearly, renal replacement therapy is an integral component of critical care. It's something which I'm very fond of and I like a lot. But here is the waste, 32 kilograms of waste created by continuous renal replacement therapy for 1 day. This includes a line change, but it is eye-openingly shocking. To finish, colleagues of mine looked at potential impact of providing more renal replacement therapy than necessary. So the guidelines recommend a dose of around 25 mL per kilo per hour. And my pharmacy colleagues, who are very aware of the costs, the financial costs of renal replacement therapy fluid, performed an audit and looked at the occasions when patients received more than the recommended dose. And as shown here, for 70% of the renal replacement therapy days, the patients received a higher dose, more than recommended and more than necessary. And they calculated that this translated into extra costs. And if we as healthcare professionals had stuck with the guidelines and provide around 25 mL per kilo as recommended, we could have saved a lot of money, which we could have used for the healthcare of other patients. And importantly, we would have led to a significant reduction of CO2 emission, because for every bag of renal replacement therapy used, a lorry has to obviously come and bring the fluid in large boxes, which then have to be stored in the hospital and create waste. So I believe there are plenty of opportunities now where we have clear evidence that our healthcare directly contributes to CO2 emission in the intensive care unit, and addressing them will not only help the environment, but will also save some costs and potentially benefit the patient, for instance, by having less blood tests and saving blood. So I want to finish here. I hope I've convinced you that there is a bi-directional relationship between the climate, between healthcare and the environment. And we have a social responsibility to address this. Thank you for your attention.
Thank you very much, Marlies. That was a very concise overview. I think you've dealt with different aspects. You've shown us what is in store for us, what we will probably be expecting in the near future when the impact of climate change will be there. You've shown also about the changes in infectious diseases that we will be confronted with in different parts of the world. And this is, of course, a dynamic that will be there for everyone, no matter where you are. And you very nicely showed also a number of things that are happening under our eyes every day, but where we probably fail to understand properly what the impact is on the environment. I think the example of renal replacement therapy was very nice in a way, but also that adhering to guidelines actually is also has significant impacts on healthcare. So in fact, I think you've perfectly set the scene for our next speaker, Ricard Ferrer. Ricard is from Barcelona, Spain, works in the Vallebron Hospital, and he will be discussing on how we all can contribute to more sustainable intensive care. Ricard, the floor is yours.
Thank you, Jan, for the introduction, and thank you for the invitation to this webinar for this very important topic. So I'm going to discuss about how we can all contribute. I don't have conflicts of interest for this talk, just to mention that I am part of the editorial team of Intensive Care Medicine, and most of the papers that I'm going to cite are coming from a special series that the journal dedicate to this, as I said, very important topic. So you will find a lot of information in this series in intensive care medicine. I'm going to reinforce the message of Marlies, but saying that this is not for the future, this is a reality. The climate is getting violent. I want to remind you that a month ago we have more than 200 casualties in Valencia, in Spain, in the Mediterranean coast. And of course, this is affecting hospitals and ICU, but also during summer times in the south of Europe, you have much more cases of heat stroke and also infectious disease, as has been mentioned. But we have, during the last summers, local cases of dengue, not imported, local, generated, and also hemorrhagic fevers, more typical from tropical weathers. And as has been said, the hospitals are contributing. It's been calculated that 10% of the emissions are coming from hospitals because of the activity done inside of the hospitals, but also the surrounding activity that we need to make the hospital work. So 10%, it's really a lot because if the target is to reduce 80-90% of the greenhouse emissions in 250, if we consider that the healthcare system is out of the equation, that will be impossible because by now we are contributing 10%. So we need to be involved. This is a very important message because we cannot consider that we are here for saving lives. So climate is, a second target. No, we have to be involved, and we can do things better, being more sustainable with our patients. Sometimes the impression, and sometimes the patients feel that if we try to go green, maybe this is going to impact the care we're providing to them. And I will try to show you some examples. This is not true. We can do things better with better patient outcome and better environmental outcome. So those are some of the examples of things that we can do better. And of course, with this target of reducing the impact. So it has been calculated, and this is again published in Intensive Care Medicine, four different hospitals, a lot of variability. But we can say that between 80 and 180 kilos of CO2 are produced per patient per day in the ICUs. And this is coming mainly from energy consumption, consumables, pharmacy, and others. And I think the previous comment was very valuable. What about consumables? Because before COVID, we have the philosophy that we have the consumables that we just need. Just in time, it was the philosophy, just in time, only the things that we really need for that specific day. Now, after COVID, we have the philosophy, just in case. We move to just in case. So we are collecting thousands of masks, thousands of tracheostomy kits, thousands of everything, just in case we have problems during the outbreaks for treating our patients. And this is, again, going against environmental targets. So we should come little by little to the previous philosophy of just in time and not just in case with the consumable. The waste production in these ICUs are very variable again, but each patient in the ICU produce several kilos of waste per patient and per day. Look to the energy consumption for the different equipment that we have in the ICU surrounding the patient. We have ventilators, we have infusion pumps, we have feeding pumps, we have bedside monitors, etc. And look to the different energy consumption between the production mode and the standby mode is not very important. So if we equip the equipment that we are not using in a standby mode, we are consuming a lot of energy that in fact is not producing any value. And in many cases, we can go safely to a shutdown mode. And this is something that is feasible and is impacting in the energy consumption in our ICUs. In the previous talk, it has been discussed about laboratory measurements. This is very important because on the left, you have a cartoon showing the amount of energy and raw material that is needed to do just a blood gas analysis, for example, and it has, of course, not only the impact in the production, also the human resources, also the risk related with the phlebotomies, the financial cost, of course, but also the environmental impact. And several strategies that can be helpful is, of course, to reduce the unnecessary. This is a very important message about no value intervention or low quality interventions, and go only for interventions that add value to patients. I will repeat this several times. Try to bundle the test, use analyzers that need a small blood volume, do green purchasing, so select providers that have less packaging and use sustainable materials, try to recycle, and found alternatives to phlebotomy. This is an example in a case of microbiology test. So that diagnostic stewardship is very important. In the ICU, we have a trend when a patient has fever of doing pan cultures to culture everything, instead of doing the culture, maybe blood culture, and a culture of the source of infection. Where is the suspicion? With that strategy, we will take better decisions because we will not be confused with many cultures that are just adding no's to other clinical decisions, but also we will be much more sustainable. So incorporate that in your decision making. What about biomarkers? We need biomarkers when we have uncertainty. But in many situations, we are convinced that the patient have the diagnosis that we are suspicion, and we are just doing the biomarker just by routine or just to confirm something that we are convinced the pretest probability is close to 100%. So why to spend money and to spend climate damage just doing something that we know that is not going to change our decision? In fact, it's not going to change other decisions. What about antibiotics? Antibiotics are a very important medication. Of course, the antibiotics save lives, but also they have an important impact because not only the production and the transportation and the administration consumes energy and affect the planet, also the same antimicrobials are adding danger in terms of generation of antibiotic resistance. But there are interventions like this one in the Netherlands showing that if you use biomarkers with a good algorithm, you can reduce antibiotic consumption, which is fantastic. You can reduce adverse events, which is fantastic, and you can reduce mortality. So in this case, you use biomarkers in a way that you can avoid use of additional antibiotics that in fact they are not adding value to patients, that are adding harm to patients with additional cost. And the impact in mortality is maintained 1 year later. So imagine a strategy that saves antibiotics, that take care of the climate, and at the same time save lives. So this is important. These type of strategies are in favor of the patient and at the same time in favor of the environmental. What about water? Water is also very important. We consume a lot of water per patient in the ICU. We can go for water-free patient care if we use alternatives that are also sustainable. Also, we need to use wastewater filtration technology, because if we are not doing that, we are sending to the water pumps, we are sending microorganisms, because you know that the sinks of the ICU sometimes are colonized by multi-drug resistant microorganisms, but also we send drugs like antibiotics. So this type of intervention, try to reduce water consumption, try to have a filtration technology before releasing the water to the system. Those are interventions that can be done. Of course, this is sometimes is not in our hand. We have to work together with the engineers in our hospitals. We can try to reduce the fluid administration to patients. Several interventions has done that. The intention of this intervention of fluid restriction is to save life, to avoid fluid overload, but in fact they didn't save life. But my message here in this case is that you can use in this intervention they use much less serum. So that means that you avoid water use, but also plastic use and manpower. And at the same time, it's safe for patients because the mortality has no change and the morbidity has no change. So this type of intervention, when it's not needed with this low value, can be avoided. So there are several interventions. Most of the interventions are based in green teams that are going to discuss later. In intensive care medicine, it's also published several examples of limiting low value care. Those are quality improvement interventions that are mainly focused in reducing blood test analysis, X-ray when are necessary, or red blood cell transfusions when they are unnecessary. And they succeed, and most of them are educational strategies that convince physicians that some of these tests are not needed or some of these interventions are not needed, and they improve the quality of care, and at the same time, they reduce the environmental impact and the cost. This is another example coming from infectious disease. This is about rapid diagnostic tests. Rapid diagnostic tests can be very useful, but as was shown in this study 9 years ago, the impact is when you link rapid diagnostic test, microbiological rapid diagnostic test, or molecular test to stewardship, antimicrobial stewardship. If there is not to antimicrobial stewardship, rapid diagnostic tests do not add value. So it behaves the same like the traditional microbiology. So think about it. If you are able to put stewardship when you have the results of rapid diagnostic tests, this is adding value to patients. You can spend money and impact on that. But if you're not going to put the expert there, then don't do it. It's just adding cost and impact. Another important publication, again in intensive care medicine, is about switching oral to oral medication when it's possible. The example of paracetamol, which is very simple. So you can keep the patient without pain, just switching to oral route. And in that specific intervention, they can reduce the amount of patients receiving intravenous paracetamol, and they analyze the impact in CO2 emissions per month and in waste production per month. Of course, you spare a lot in serum, in bags, and in lines using oral paracetamol. So the patient do well, and the impact is less. Also, the way that we dilute the medication. So this is an editorial, and Nicole can talk about that. Is about selecting the adequate intravenous bags. Because if we dilute a lot the medication, we are going to generate much more waste. So the message is select the smallest suitable bag size for the infusion of medication, because this is, again, is going to impact and is not adding any value for patient care. Waste management is probably a long-hanging fruit. That means that this is something that we can impact a lot, and it's not going to cost you a lot of effort. So in that intervention, they were just able to reduce the infectious waste. This is very important because you know that infectious waste has a specific treatment, is much more expensive to handle, is much more harmful for the environment because it requires incineration, and at the same time they increase the waste that is recycled. So if you have a good selection of waste and you only release in the infection waste bag what really needs this specific treatment, you can impact a lot. So facilitate waste segregation. It's very important. Also to use containers that are reusable. So when you share pharmacy or disposables in the ICU, now we have changed in my hospital to reusable containers, and of course, you avoid to use single-use containers. Educate the staff and make the intensive care team aware of the program goals. So we go for this circular economy that pay attention to priority 1, which is production and transport of healthcare supplies, priority 2, which is pay attention to consumption of supplies, and priority 3, which is this waste management, which is very important. final message is about single use or reusable use of different equipment, in this case, scissors. This is something that needs specific analysis. The initial impression is that reusing is better than single use, of course, but the final decision should take into account which is the sterilization mode. So chemical sterilization usually is better than steam sterilizers that can consume a lot of energy. So depending on the sterilization strategy, the sustainability could be completely different. And maybe if you are using steam sterilizers that consume a lot of energy, maybe it's better single use than reusable. So this needs a specific analysis. And when we did the economic evaluations of the interventions in the ICU, we have to include the environmental impact. Sometimes we are just looking to money, but some of the intervention can save money, but on the other side can have an impact on the environment. So we have to include this in our decision making if we are taking decisions at ICU level. So my conclusion is for the ESICM Green Paper that Jan leader last year, where you can find most of these strategies included in these 4 domains of these papers. Thank you for your attention, and thank you to my ICU Green team that recently we won the prize as the most sustainable ICU in Spain.
Thank you very much, and congratulations for that, Ricard. I think you really very nicely showed that all of us can contribute to more sustainable intensive care. And you've shown us actually that in probably every domain, every aspect of care, there are potential targets for more environmentally friendly solutions. I do think that you will agree with me that, of course, all of this is possible without jeopardizing the quality of care to the patient, because sometimes people argue, well, if you do these kind of things, you will degrade the quality of care, which I'm personally convinced of, that you can do this and maintain, and in some situations even improve the quality of care. Before we go to the next speaker, I do want to remind everybody that if you have any questions, you can add them to the chat, and we will deal with them after the next presentation. Because I think by now everybody understands the need as well as the urgency to do some, and probably everybody's just like waiting. Okay, how can we bring this to the bedside? So, and this is actually the topic for the next and the final speaker in this webinar, Nicole Hunveld from Erasmus Medical Center in Rotterdam, will be discussing on how to build green teams, tips and tricks that Nicole will share from her own experience. Nicole, the floor is yours.
Yes, thank you, Jan, and good afternoon to everybody. I will tell you, I think, the Rotterdam story about how we started a green team and what we are doing at the moment. But I have a disclosure. First, I'm a principal investigator of the Escher project regarding circular hospitals. This is a 7 million project together with industry, funded by the Dutch Research Agenda. I also always show a green disclosure about traveling, and today it's very green because this is an online event. So now we're good to go. I'll tell you a little bit more. If we go back to the green paper of the ESICM, the focus of my green team is on the left upper panel, so clinical care. We really focus on the patient, and if we get lost or we don't know what to do, we go back to the patient, and it really helps us in focusing. It also helps that we have data from our own ICU. We performed the material flow analysis years ago. And because we have these data, we also know what we need to change. We can prioritize. And we also did this together with the nurses already a couple of years ago, and the green team then took over. In my ICU, and this is just a product that we use 17 kilograms of product every day for each patient. This equals 12 kilograms of CO2 emission. That's 50 4 kilometers by car. For these products, 4 square meters of landfill are used and 300 liters of water. And this is for every patient every day. And my ICU has approximately 50 patients per day, so then you know what happens there from an environmental perspective. These data were gathered from this big material flow analysis, and this is the real chart. In the ICM paper, we show a simplified version, but this is the real chart. And I think we are really shocked by the fact that we use 247,000 kilograms of product every year. It's on the left side. What also shocked us that the plastics that we use, and this is the material itself, but also the packaging, in my ICU, that's 14 different types of plastic. And only 2 or 3 of those are pure, but we don't know from the outside. So if you would like to recycle this stream, that's almost impossible because you don't know what you're dealing with. So this is still a challenge, but also a remark that if you start procuring or whatsoever, that you need to be aware of the plastics that the package and the product itself contain, because that might help you in the end in reducing waste. With this chart, we decided our hotspots in the ICU, and that was also the start of our green team. Because we had those data per patient, we were able to make very good charts. And these charts were convincing for the nursing staff because they were really asking me like, do we use 108 gloves per patient per day? I said, yes, to be honest, that's what happens here. That's a lot. Do I do that? Yes, you do that as well. Okay. And then you could see also the mind shift there, like, okay, I am doing this, but I'm also the one that can change it. And we really focused on that change. And we also said, okay, medication, since I'm the pharmacist in the ICU, I will take care of the medication, but I need your help there if we want to use less infusion bags, for example. What we did with these data, we started that green team. This was somewhere, I think, in the middle of COVID in 2020. But we said, okay, we do know where to start. Let's meet every 2 weeks. It's always a 30-minute meeting, very short, with an easy agenda. We have minutes there that we share, but it's all really action-based. And I think important to tell you that we don't have a fixed green team. It's a dynamic green team. Every 2 weeks, there can be other people, but there's always someone from infection prevention, one of the nurses, sometimes more nurses, a care assistant. Also, the manager of the ICU and the head of department can be there, but they're not always needed. We keep them informed, and if there are questions, we just walk into their office and ask them what we need. There's a quality lead there, and I'm there as the pharmacist. And very often there are students that are doing a green project involved. We always ask them to join the green team. They share their results and they discuss what they can change. There are residents that really like to be there, or fellows doing their internship in the ICU. We often ask the waste manager if he can join, someone from procurement. So we really keep this a dynamic because of all the different working hours of people. It's not easy to get a team together. So we just tell everybody, feel free to join. If you're not there, okay, please send us an email if you can join, or show us the status of your project. But if you're not there, it's also okay. With this green team, we also collected data. We asked a student to design some kind of, because it's not there yet, we're still trying to develop it, a green team dashboard. So what we did is we coupled all the procurement data from the ICU to the admission data, so we know exactly what happens at a certain time point per patient per day. This is based on the data we gathered from the material flow analysis, but we would like to have this real time. And what we showed, and now we compare data of 2019 and 2023, is that our gloves went from 108 per patient per day to 91. So this is 16% decrease, which is significant, but also very important because this is what everybody in the ICU did. They were all helping with this project. We switched from gowns to aprons. Gowns are only needed with is in isolation, a patient in isolation. So we said if it's not a patient in isolation, you can use an apron. So we went down in the gowns from 16 to 6. And of course, we went up with aprons, but only 8 per patient per day. And aprons are 50% less plastic than the gowns. We also said, okay, do we really need those pupil lights? We found out that we had single-use ones. Nobody knew how they ended up in the ICU, but they were there all of a sudden. But then one of the nurses said, yeah, we're good to go with the lights that are already in the room. We don't need these lights. So we just took them out of the stock, and that saves 500 years of lights per year. The paracetamol challenge was a big success. We were able to change the way we use it. We even switched our protocol, and now the oral paracetamol is first choice drug in my ICU. We were also able to start a recycling program on our dialysis bags, so they're all being recycled now, and that saves us 10,000 kilograms of plastic per year. And one thing that was remarkable, but it could be a post-COVID effect, we use more masks. We went from 9 up to 12. We don't know exactly what happened there, but I asked a couple of nurses and they think they're more aware since the COVID period, so they used those a little more. And also very important to state, we will dive into our quality numbers and quality of care. We do have those numbers, but I can already tell you that our mortality rate remained the same. So with using less products, our mortality rate didn't change at all. Then some tips and tricks I would like to share. We do have 2 wards, and in the beginning it was really a challenge to engage them both, because sometimes the nurse from one ward was there and the other couldn't come. So sometimes it felt a bit of a challenge between those wards, and I don't like that, because that should not be the goal. So we discussed this, and then we also say we need to accept that these 2 wards have different dynamics and maybe a different rhythm, and it's fine if projects go slow in one and a bit quicker in the other. That's not a problem, as long as we keep sharing this with each other, and we also help each other out there. We also thought, okay, if we put something in the newsletter, that's fine. That's normal communication, but that didn't work. So we really increased the way we communicate. We use the TV screens that are in the ward for the nursing people there and the staff. We also make posters like the one I just showed you. We make short movies sometimes that we share within the ward. And I got really good help there from someone from communication. I just asked her, like, okay, help us out. We need to communicate way more than we're used to. I need your advice there. And she's still helping. We also noticed that smaller projects are way more successful than bigger ones. Bigger ones often fail, I think, because we needed too many people involved there, and that's not something nurses can easily do on a working day. So we really go for small projects, and then they are successful, and then nurses like it and they can do another one. We also decided to go for complete projects. In the beginning, I thought we could test some things, like washable mats, for instance, but then the size wasn't right. And then people said, you had those mats, what's happening there? But then we don't have the smaller ones yet. So then people are not motivated anymore. So I think I learned myself that if you want to do this, just test it at the moment you know for sure that a company can deliver it to you. Otherwise, people stop. We also show the results, also outside the ICU. So we have a green team structure in my hospital. We have over 50 green teams at the moment, but we also share the ICU data there because it creates a lot of, I think, communication in both ways. Because if the cardiology green team says, oh, nice, I can use that as well, I help them, but they also give me their information in return, and we can learn from each other all the time. What also helped is that we had a lot of success with the paracetamol challenge because the nurses took the lead there. We thought, okay, let's just use less IV paracetamol, But then the nurses told me, yeah, it's really nice because I can ask the intensivist if he can change the order. I really like that because it's my patient and I know what happens there. I said, okay, that's fine. If you can do it in that way, just go for it. And then that really created a lot of fun because they really told me, okay, it went down, and I changed it today. They also noticed that the doctors were really willing to help the nurses there as well. And another thing that I often noticed, you are being watched. So if you walk into this patient room, nurses really see that you as intensivist are wearing gloves, putting on a mask, etc., and they copy it. So be aware that if you don't want to use it, then you should be really clear there. We often talk about the footprint. One other way of approaching is how can you increase your own handprint by being a role model, by bringing a water bottle that you can reuse, a coffee cup that's reusable, and a lunchbox, etc. That also helps. Don't wear gloves or gowns if you don't need them, and show others that you don't need them. Rethink what you need. Quite often, I think we enter a room and there are already products that are unpacked, which is not needed. So sometimes you don't need it and you can just tell it, oh, you can leave it there. I will tell you if I need it. And it's already been mentioned, also switch to oral medication if possible. Ask your pharmacist. There are many, many, many options there. And then I would like to finish with go green. Do it as a team. Make it fun. And don't forget to show your results. Thank you.
Wonderful. Thank you very much for that, Nicole. I think that was truly inspiring. I'm sure that many of our attendees actually got a lot of practical ideas from your presentation. We have a few minutes for a few questions, and well, let me maybe continue where Nicole left things. I mean, she shared a lot of ideas and a lot of tips and tricks. Maybe I can also ask both Marlies and Ricard if they would have like, well, not 10, but maybe 1 or 2 practical tips that they want to share with our attendees today.
Well, in my case is that you have to include the environmental perspective in every decision or every analysis you are doing in the ICU. As head of department, for example, we are adding in any public tender we are doing for buying equipment or disposable, we are including an environmental component to that. And I think, of course, we need the participation of the departments in the hospitals, but they are very aligned also in that. And I think to have this perspective for every decision, I think it's the right way to go.
Thank you for that, Ricard. Any ideas from your side, Marlies?
There are 2 ideas. Firstly, we're still in the learning phase here, where we need ideas and we are looking up to other people who are already far ahead. But there's one thing which I think has worked for us is so combining these projects with things that people also already need anyway. So I showed you this project about with the renal replacement therapy fluid, but actually it was led by a pharmacy student who needed to do a project, a quality improvement project. And so ultimately it served everybody. It served the person who did the audit because she completed her project. It served the pharmacy department, they got really good data. It has helped the clinicians understanding things better. And it has opened our eyes. And ultimately, I hope it will also, it may not, but it will not harm patients. And hopefully they will also be benefiting from this. So it's something that ultimately, that at the end helps everybody and can also help clinicians at the bedside with whatever they need to do the task, then I think it is more likely to work.
It's probably the point where practicality and sustainability meet, and where people realize that, well, yes, this may be more environmentally friendly, but this is also more practical and maybe safer and maybe faster and maybe easier. That is probably the sweet spot that you need to look out for. Now, from your practical experience, and now I'm looking at Nicole and Ricard because you're already a bit advanced in this. is there anything that you would recommend, or what your experience was like the low-hanging fruit, the eye-opener for a lot of people, where you get with a minimum of investment, you get a maximum of return?
Well, I think explaining to people why gloves are made of nitrile and how that works, that the nitrile is produced in Spain, it's transferred to Thailand, there they make the gloves, they box them and they send them back to the Netherlands. That was an eye-opener for many people, because we often have no clue what happens there. But if you tell this and you share it, and you can also show the data, then people really start thinking, I can use less. And that really worked in my ICU.
All right, thank you very much. Ricard,
Yes,
can you share
yes, from my side, the first intervention we did is to reduce to stop using gowns for the relatives. Maybe you are using, maybe you are not using. We were using it, and then with infection control, we agreed that this is not increasing safety for the relative, not for the patient, and except the patients that need isolation, of course. So we stopped doing that, and the impact was huge because we stopped consuming this type of disposables. We also now we are including patients and family in the green team, which I think is something that also can be useful for some of the people that are listening in this session. We have an association of patients that we have meeting with them every several months, and they want to be part of our decision making, and they review some protocols and some interventions we are doing, and we included them in the green team. Let's see, we have some expectations in that, and their perspective also will be important in the same example I mentioned to you. So also, I think this is something we have not discussed during our presentations, is to include the patients in those type of activities.
Thank you very much for that, Ricard. It's clear that practices differ around the world clearly, and there's of course no single solution that is applicable to every situation, to every hospital, to every country. Now, I think some of you mentioned low value care. Probably all of you mentioned low value care and the problem with that. Now, it seems to me that quite often when we talk about sustainability, it's much easier to talk about the gowns, to talk about the gloves, but trying to de-implement low value care is a bit more challenging. Do you have any idea why this is and how we can overcome this?
I think I often call it evidence-based de-implementation. Sometimes we need evidence there. And if it's a big deal, then we also gather evidence now. The beginning was a bit like, do we really need to show that that we don't need to draw that many cultures? But sometimes it really helps if you can show that less is okay and that people are convinced then. So we switched a strategy there. And we do this together with infection prevention, but in some cases it really worked.
Yes,
thank you very much, Nicole.
Sorry, sometimes it's related to all practices because you standardize something in the past, but time have changed many things. For example, daily X-ray, chest X-ray to patient. This is something that was established many years ago, could be the standard of care in many ICUs, but now we have thoracic echography, for example, and we are still using the old protocol. So if you stop doing that, probably is safe, and you only do the X-ray when it's needed, and you can stop doing the protocol. The same from blood gas analysis every certain time. There are still ICUs doing every 6 hours to all ventilated patients. Why all patients are with pulse oximeter? Some of them are with capnography. Are we convinced that we need blood gas analysis every 6 hours? But in the past, probably it was useful when we have less monitoring, non-invasive monitoring. So we have to adapt our protocols to the new situation. And of course, it needs analysis and time, but it's a good effort to do that.
Thank you. The adoption clearly an issue. Marlies, final comment on your side.
I do honestly, I fully understand. I mean, all of us come to work to do a good job. We want to do a good job. We want to help the patients, and we don't want to make mistakes, and we don't want to miss opportunities to get people better. And in the past, we have been taught, a lot of us, it includes me, my colleagues, the nurses at the bedside, that you monitor and you check this and the other. And we have to now get people to we have to convince them that a few things are no longer necessary. But it's obviously hard because we can provoke anxiety. Nobody wants to be responsible for some deterioration that was missed. So I think it is, as Ricard said, or as Nicole said, the need for data showing that a little bit less is safe and does not harm the patient, and in fact may be beneficial for patients and healthcare and the environment. But people feel anxious, understandably, because they were taught something else a few years ago.
Thank you for sharing your insights, all of you. I'd love to talk and discuss a little bit longer, but I think we're at the end of this webinar. It was a pleasure to be here with you and to discuss about environmental sustainability, how to bring it to the website. I enjoyed it a lot. I learned a lot, and I hope also our audience has a number of ideas that they can bring to the bedside to their patients. So before ending, I would like to just ask each one of you to have like your main take-home message to our audience. Let's start with Marlies.
Okay. So in a world where green meets care, where healing hands show love and share, with every choice, let nature thrive. Together we can keep hope alive.
Thank you very much, Marlies. That's a very nice one. Nicole, the challenge is yours now.
Yeah, I'll stick to my previous one. Go green, do it together, make it fun, and show your results.
Wonderful. Very clear message. Ricard.
Sorry, I don't have a poet perspective, so I am going straight for include.
You can sing a song if you want.
Also, I am bad in that, so not poetry, no singing. So sorry about that. So include the environmental perspective in all your decisions at bedside, but also when you are managing the ICU.
Okay, thank you very much for sharing your wisdom. Thank you to the audience for being here. I hope you enjoyed it. And I hope we meet each other at one of the future ESICM webinars. Thank you very much, everybody.